Dental professionals are trusted to provide competent care for all patients. However, current dental training often focuses on the most typical patient, which can translate to gaps in care when treating patients with mouth morphologies that deviate from the norm. This results in fewer dentists that can accommodate special needs patients with atypical mouth morphologies. These patients are often on waiting lists for months or even years before they can undergo a simple dental procedure, such as a teeth cleaning. Dental students begin training for clinical settings early on in their education, typically using a mannequin with removable teeth called a typodont. This gold standard training device is used to practice procedures such as fillings, cleanings, and restorative work. Current dental mannequins provide minimal training representative of patients with atypical mouth morphologies. For example, patients with Down syndrome tend to have larger tongues relative to their mouths, crossbites, and higher vaulted palates. Patients with cerebral palsy have narrower mouths, more crowding, and higher arched palates. Based on what we saw in dental clinics, we created our first prototype. We decided to focus our training device to include 3 main features: an adjustable jaw, a tongue, and removable teeth. These features addressed morphological features that differ in special needs patients and are not present in typical dental trainers. A thorough risk and hazards analysis then allowed us to prepare for and mitigate possible issues that could arise from our training device. The main areas of risk we analyzed were associated with improper training, potential allergens, and falling pieces of the device. We cleared our initial designs with our mentors, Dr. Tyclet, Director of the Center for Patients with Special Needs, and Dr. Samosky, Director of Medical Simulation. Input from both a clinician and an expert in the field of medical trainers was beneficial in ensuring that the unmet needs were addressed. Through repeated iterations, we utilized feedback from mentors and Fall Design Expo attendees to refine our prototype design. Our final model utilized a metal skull exterior and a metal pole to attach the remaining features. We deconstructed and rebuilt a commercially used articulator to attach the bottom jaw onto a track. This allowed the jaw to move vertically along the track to mimic over and underbite conditions. Furthermore, we attached a horizontal slider across the bottom of the jaw to mimic crossbites. The tongue was attached via Velcro to the inside of the skull. We formed the tongue from special effects gelatin to mimic the flexibility and texture of a real tongue. We performed several verification tests to determine the usability and accuracy of the device. We confirmed the anatomical accuracy of our trainer and ensured that the mouth was adjustable to the desired dimensions. We tested the removability of the teeth, the compatibility of the trainer with the current mount, and the weight burden. Following verification of our device, we moved on to validation. We recruited dental students and practicing dentists to use our device and fill out surveys about the experience. We used verification and validation data to determine if our device met our acceptance criteria and to make changes to the design accordingly. For example, we found that the adjustability of the tongue was not needed to achieve our intended mouth morphologies, and so it was subsequently omitted as a feature. We hope this device can be used to give dental students and professionals a more inclusive simulation education to improve the standard of care for patients that have atypical mouth morphologies.